Wish you a very good evening. I, Alad Mahajani, Vice President Marketing, Juventus, take immense pleasure in welcoming each one of you for a scientific interaction on how to select among DOACs in AF with Dr. Robert Giugliano, the Principal Investigator of Engage AF TME. Juventus, as an organization, has been dedicated to bring joy and jubilation in people's life. Juventus has been at the forefront of basic and advanced research through its R&D center and has been instrumental in launching many products, molecules for the first time in the field of cardiology and diabetology. To name a few, we have the pleasure of introducing first time in India ibutylide, Fibricor, Ifenodipin, Ifenocar, S-amlodipin, Eslo, with research from MCure, and Trelagliptin, once a week DPP-4 inhibitor Trelaglip. These molecules have been synthesized in Juventus R&D, and Juventus has conducted clinical trials, phase 3 and phase 4 in India, and then procured license from DCGI and then marketed it in Indian population. Today, Juventus takes pleasure in introducing Edoxaban for the first time in the Indian market. Edoxaban, as we all know, is a DOAC which has been launched internationally in 2015, and it would be the subject matter for discussion today. Before we proceed ahead, I would request the technical team to share insight into Juventus for the next 3 minutes or so.
In 500 BC, an era which witnessed probably the greatest invention ever, the invention of a wheel. It was not long after the discovery that its true potential was realized. From the sheds of a simple pottery in the ancient era to become the basic principle behind almost every mechanical device, the phenomenal journey of a wheel instinctively inspires achievement, dependability, and a sense of trust. Similar has been the glorious journey of Zuventus Healthcare, which is dedicated to bring joy and jubilation in people's lives. Our journey began as an enterprising initiative in 2002 under the dynamic leadership of the finest professionals from the industry. Since Zuventus began taking shape, within just 2 decades, Zuventus has surpassed numerous milestones, achieving a remarkable turnover of $280 million. Innovation and technology being the core essence of our growth. All our operations are integrated under SAP data processing application. Auditing by KPMG ensures that Zuventus adheres to global governance standards and practices. Our state-of-the-art manufacturing plant in Jammu has strong capabilities of producing cephalosporins in various dosage forms. Augmenting our production capabilities are our facilities in Sikkim and Bengaluru. Each of these facilities strictly adhere to stringent quality norms as per WHO, CGMP, GLP and GCP guidelines. Our DSIR approved R&D facility in Pune remains updated with modern research infrastructure and analytical instruments. Together with a talented team of experienced research scientists, Zuventus is relentlessly striving for patient wellness by exploring better efficacy, better compliance, and affordable treatment alternatives. With a dedicated team of more than 2,500 representatives spread across 326 headquarters and 7 therapy-specific SBUs. We are one of the leading pharmaceutical companies in India. Our 3 packaging and warehousing units for raw materials and finished products are spread across an area of 2 lakh square feet. A robust product portfolio and a strong distribution network have been the key features of our achievements. Our facilities have undergone rigorous audits and earned approvals from various regulatory agencies, qualifying them for inspection by prominent nations such as Peru, Colombia, and the Philippines. Initiating our global journey in Africa, we have since expanded our operations across South America, Central America, and Southeast Asia. Healthier You, our first direct-to-consumer division, focuses on the extensive potential of online consumer healthcare and wellness demands. With the unwavering trust of doctors from across the country, we are successful in establishing an array of mega brands, which are amongst the leading products in the Indian pharma market. We stand amongst the leaders in serving critical therapy areas like hepatology, gynecology, anti-infectives, mainly cephalosporins, and emerging strongly in respiratory and gastroenterology. Our resolve towards innovation becomes stronger with the emergence of newer products for newer therapy areas. Zuventus is amongst the top companies to launch many first-time in India molecules thanks to our R&D. With the introduction of transdermal patches in COPD and pain management, Zuventus is extending newer technological innovations to ensure better treatment outcomes. It is indeed your enduring sense of trust and support which will transform our resolve into success. We urge you to join us to take this initiative to the next level. Zuventus, dedicated to bring joy and jubilation in people's lives.
We sincerely thank you. We sincerely thank the August gathering for giving a patient hearing. And now we would proceed ahead with the session of the day, and would like to introduce and welcome Dr. Bhupesh Diwan, the moderator of the day. I would request tech team to share the slides. Yeah. So welcome, Dr. Bhupesh Diwan, sir. Dr. Bhupesh Diwan, sir, is the Director of Medical Services, Juventus Healthcare Limited. Dr. Diwan has an extensive background in clinical research, having conducted over 100 trials, and has published widely in national and international journals. He has a proven expertise in product introduction and drug development, coupled with significant Indian and international regulatory experience like DCGI, US FDA, and EMA. He has been highly experienced in medical education and having delivered more than 1,500 CME lectures both in India and internationally. Dr. Diwan, we welcome you and hand over the session to you to take it ahead. Thank you once again.
Thank you very much, Alak. And it's my privilege over here to introduce today the speaker of the day, Dr. Robert Giugliano. Dr. Robert Giugliano is always as smart as he looks now. So you can get a wealth of knowledge from him in his expertise, in his areas. And he is the senior investigator of the TIMI study group. He's a professor of medicine at Harvard Medical School. He has made significant contribution to his area of expertise, especially in novel drug or novel lipid-lowering drugs, antithrombotic therapies for atrial fibrillation and acute coronary syndrome. He has authored over 500 articles and serves on multiple prominent editorial boards. Dr. Robert is the principal investigator for TIMI study of Edoxaban also, which was one of the landmark studies called Engage AF TIMI 48 study. Dr. Robert is a member of executive committee for major trials such as Improve It, Fourier trial, Vesalius trial, and Azalea TIMI 71 trial. So with his presence, we are really privileged and would like to know more from him and enjoy his speech. Dr. Robert, over to you, please.
Thank you for the kind introduction, Dr. Diwan. Let me share my slides. Share. Okay, let's get this in presentation mode. Good. Are you able to see my slides now?
Yes, it's visible.
Okay, great. All right. Well, thank you for the invitation to present on this very important topic of how one selects among the various anticoagulant agents that are available now for patients with atrial fibrillation. And what I have a picture here to the right is of our cardiovascular center at the Brigham and Women's Hospital in Boston. It's one of the Harvard teaching hospitals, and I play a couple of roles here. On the 9th floor is our cardiac intensive care unit where I attend. On our 2nd floor is the outpatient ambulatory clinic. And then connected to this building is our research offices where I spend most of my time these days in the TIMI study group working on clinical trials with novel therapies. Here are my relevant disclosures. You'll see these are largely related to work that the TIMI group does with various pharmaceutical companies to develop new therapies. And also I participate in many lectures and CME programs and consult with companies on their newer therapies. I have 5 topics I wanted to cover today. take a look comparing the 4 available direct-acting oral anticoagulants, or DOACs. Some refer to them as NOACs, novel oral anticoagulants, but they've now been around for 16 years, so not as novel anymore. We'll review the main findings from the 4 large DOAC versus warfarin randomized clinical trials. The bulk of the talk will be looking at how do we select, particularly in our vulnerable patients, amongst the DOACs, because the young, healthy people will do well with any of the agents, or even warfarin for that matter. So I focused really on the more vulnerable, high-risk patients. We'll have a brief consideration of drug-drug interactions, which is one important way to distinguish, which of the DOACs is optimal for your patient, to look at the concomitant medications. And then I'll share with you some approaches to select the optimal oral anticoagulants. So this is a timeline of the advances in oral anticoagulants. For 50 some years, we had only one choice, and they were vitamin K antagonists. And that database in atrial fibrillation stems from 6 trials and fewer than 3,000 patients from around 1990 that were conducted. Then starting in 2009, and on an almost annual basis, we had the introduction of a new oral anticoagulant, dabigatran, in the RELY trial in 2009. Then Rocket AF introduced rivaroxaban, Aristotle AF apixaban, and most recently in 23, the Engage AF TIMI-48 trial, which I led with Edoxaban, was conducted and published. And you'll notice that the size of these studies are in the tens of thousands of patients and far dwarf the earlier trials with warfarin versus placebo. Yet there are still some patients in whom vitamin K antagonists are preferred, specifically patients with mechanical heart valves, pregnancy, severe hepatic insufficiency, severe renal disease, although perhaps there's a role for apixaban that remains controversial, and patients on strong P-glycoprotein inducers or inhibitors as they interact with the transport of each of the DOACs. And I'll just have an asterisk there to indicate that Edoxaban was studied at a reduced dose in patients on concomitant strong PGP inhibitors. Then there are a group where warfarin may be more effective or safer, including patients with APLS, moderate to severe rheumatic mitral stenosis, extremes of body weight where there's some uncertainty about the dosing of DOACs, and then patients early after mitral valve surgery, although that even there, the DOACs, and particularly a recent publication with Edoxaban in the INVALVE trial, look promising. The majority of patients, however, should receive a DOAC, including those who do not have good control of the time and therapeutic range with a VKA, those who have failed warfarin clinically due to a stroke or a major bleed, those patients who are unable or do not prefer to have frequent dose adjustment and frequent blood testing for the INR, patients who are on medications that interfere with warfarin, particularly, for example, antibiotics, where they're needing to come on and off antibiotics, and that interferes with the INR results. And then 3 groups at the bottom, those that are moderate to high risk of bleeding, who are elderly or have mild to moderate renal dysfunction. The DOACs tend to do better than warfarin, and particularly apixaban or Edoxaban in those patients, and I'll show you the data in subsequent slides. Now, you might be asking the question, why do we need 4 DOACs? Aren't 3 enough? And it's a fair question, and I want to focus here on 2 points with regard starting with pharmacokinetics and pharmacodynamics. You see the 4 agents in the order they were introduced. Edoxaban here is a 10A inhibitor, like rivaroxaban and apixaban. Dabigatran, inhibits factor 2A. They have similar times to maximum concentration. But the metabolism through the cytochrome P450 system is an issue for rivaroxaban and apixaban. There's little metabolism through this enzyme system of Edoxaban. There's none for dabigatran. So patients on strong or multiple cytochrome P450 inhibitors would do better with Edoxaban or dabigatran. You don't have that drug-drug interaction. Bioavailability of Edoxaban is good. Notice it's quite low for dabigatran, which is why it was bound to tartaric acid to lower the gastric pH, and then that causes gastritis and more dyspepsia and potential for GI bleeding due to the low pH environment. On the other hand, rivaroxaban has an excellent bioavailability, but note the asterisk, it must be taken with food. If your patient takes it on an empty stomach, they are inadvertently dose reducing themselves, whereas there's no important food effect with apixaban or edoxaban. They are all interact with the P-glycoprotein system, as I mentioned. The protein binding is high for the 10A inhibitors. It's lower for dabigatran. That's only relevant in the sense that dabigatran can be removed by hemodialysis. Volume of distribution varies from a low of 21 liters to a maximum of 107 with edoxaban. This indicates that a significant proportion of the drug is making it into the extravascular space. And then toward the end of the dosing interval, and this drug is given once daily, some of it is coming back into the bloodstream and may then prolong its effect. So it is a once daily drug, as is rivaroxaban. And that is important for some patients who prefer once daily administration to twice daily dabigatran or apixaban. And then lastly, the renal elimination for edoxaban is intermediate between apixaban, which has the least renal elimination, and dabigatran that has the highest. And of course, if your patient has renal dysfunction, dabigatran is a difficult drug to work with because of the variability in the elimination. Whereas if a patient is on apixaban, there's much less renal elimination. That may be fine for patients with renal dysfunction, but it then relies on extra renal elimination, and one has to also think about other routes of elimination. And if patients have impairments, say in hepatic or GI elimination with that compound. And then turning our attention now to the actual trials, I want to point out that the studies had some things in common, like they were compared to warfarin, but there are other important distinguishing features. And looking at the ENGAGE-AF trial, you'll see that it was the largest study. There were 2 doses studied, 60 high dose regimen, 60 milligrams, dose reduced to 30 in patients who met certain criteria, and then a lower dose regimen, 30 milligrams, dose reduced to 15 in patients who met certain criteria. Now, the reasons for dose reduction varied across trials. Notice there was no dose reduction in RELY at all, although there were 2 dose regimens studied. And dose reduction was infrequent with apixaban and Aristotle. Fewer than 5% received the 2.5 milligram dose. So our entire experience with apixaban and atrial fibrillation with the 2.5 milligram dose is on about 450 patients. So very small experience with that reduced dose. Just catching up here. In contrast, 25% of patients were dose reduced with edoxaban. So we have a wealth of experience with 60 milligrams, 30 milligrams, and even 15 milligrams in patients who met dose criteria. Notice that edoxaban was the only study, the only drug, the only trial ENGAGE, where dose adjustment was allowed after randomization. And that was important because patients can have a change in renal function, for example, and here in this study, we did allow a downward dose adjustment. The trials were double-blind with the exception of RELY, which was an open-label study, although adjudication was blinded. And notice they varied in their risk profile, with the highest risk being ROCKET-AF. The lowest risk trial was Aristotle, and ENGAGE was in between those 2. And then the median TTR really varied quite a bit, from a low of 58%. So the warfarin management was not as good in ROCKET-AF and really substandard for many countries, whereas the time and therapeutic range for warfarin was highest in ENGAGE-AF. So you see important differences, as I showed on the prior slide, between the drugs being studied, but also important differences in the design. Now, I wish I had the ability to share with you head-to-head randomized trials in large numbers between drugs, but they just don't exist, and I don't think they ever will. Instead, we have to look at other types of data, including comparisons across trials or adjusted analyses from randomized trials. And I think those are generally better, and you'll see I'll share very little observational data or unadjusted observations. An important effort of which I and other members of the leadership of each of the trials have been working on for 5 years now is called Combine AF. I'll show you many data from this data set. It's an individual patient level meta-analysis from the randomized clinical trials of DOACs versus BKA and warfarin in atrial fibrillation. So you'll see a lot of trials from Combine or data from Combine AF, and I'm going to first start though with a paper from one of my colleagues, Christian Ruff, who was a fellow working with me and now on staff with the TIMI study group, looked at the individual trials and outcomes for each of the DOACs versus warfarin. And here I'm showing you the endpoint of stroke or systemic embolism. You see the combined effect across the trials is a 19% reduction. And only one of the trials, Rely, and at a dose of 150 milligrams, did dabigatran significantly reduce the endpoint of stroke or systemic embolism versus warfarin. The other studies had favorable trends, but not necessarily statistically significant. Aristotle with Edoxaban did just meet the statistical significance criteria. I don't think there's really any difference amongst the 3-factor 10A inhibitors here. There seemed to be a larger effect with dabigatran. Major bleeding is a little more complicated, and I'll share with you the results here. Notice one can calculate combined effect. However, the p-value for heterogeneity across the trials is highly significant. And what the statisticians have taught me is that we should not look at the combined effect when you have such heterogeneity between trials, rather look at the individual data, or in this case, it really breaks out into 2 pairs of 2 trials each. For major bleeding, there was no difference between dabigatran and warfarin, and no difference between rivaroxaban and warfarin in the Rely and Rocket trials, respectively. Whereas you see with apixaban and edoxaban, significant reductions in major bleeding compared to warfarin. So patients at highest risk would appear to do better with apixaban or edoxaban because the risk of bleeding is significantly reduced compared to warfarin. All the drugs and trials reduced intracranial hemorrhage. There's not any significant heterogeneity here, although the point estimate might be a little bit higher for the Rocket AF. Remember, those patients were higher risk and 87% had prior stroke. But one good news is that intracranial hemorrhage is significantly reduced across the board with a DOAC compared to warfarin. And in fact, that explains the bulk of the reduction in all-cause mortality, because ICHs are fatal in about 1/3 to 1/2 of the cases. And you see the mortality reductions about 10% and doesn't really vary across the trials. So that's a quick review of how the trials and drugs compare at a high level for major outcomes. And now I want to focus on the vulnerable patient. And in introducing this concept, I want to focus on initially older age, because age is really what drives many of these other comorbidities. And then I have selected six comorbidities that I can take you through the available data rather quickly to see how the DOACs compare to warfarin, and indirectly how they compare to one another. But we really should start with age. It's the great integrator. And here is just a slide I want to set the story, looking at what happens in patients treated with warfarin. And as you look at different age groups, so the gray is age under 65, and if you'll indulge me, I'll call them young patients. The orange is age 65 to 74 years, let's call them middle age, and then the elderly age 75 or greater in blue. And if you look just in warfarin now, there are no DOAC patients here. These data come from the Engage AF TIMI 48 trial warfarin patients, of which there were a little over 7,000. Stroke or systemic embolism, it doubles as you go from the youngest group to the oldest group. Ischemic stroke has a doubling in its event rate, and these are annualized event rates. Major bleeding triples, and intracranial hemorrhage, although a less common event, quadruples as you go from the youngest group, 0.3% in age under 65, to 1.2% in patients 75 or older. So you see that there's a steep gradient, particularly for bleeding endpoints, as age increases. Now, you might say, well, how did the DOAC stack up in the group we're most concerned about, those age 75 or greater, the elderly? And you can see at the top half of the slide, the outcome of stroke or systemic embolism is pretty similar for each of the DOACs. I don't see a large variation here. The net benefit is a 30% reduction in stroke or systemic embolism, a little wobble this way or that way for the individual trials and drugs, but really no apparent difference. The bottom half of the slide is very interesting and more complicated. For major bleeding, you see in the elderly, major bleeding was reduced with Edoxaban in the Aristotle trial and reduced with Edoxaban in the Engage AF2E48 trial. And there was significant heterogeneity such that when you look at the data with dabigatran and rivaroxaban, there's no difference. If anything, the point estimates indicate that elderly patients who received dabigatran or rivaroxaban tended to have more bleeding than with warfarin. And the point estimates were 10% and 14% increase in that risk ratio of major bleeding with dabigatran or rivaroxaban, whereas with apixaban or Edoxaban, there's somewhere on the order of a 18 to 33% reduction. So significant reduction there in major bleeding. Now, one might say, what about using lower doses? We did study a second dosing regimen that is currently not approved for use, called the 30/15 milligram regimen, as opposed to the approved regimen of 60 dose reduced to 30. And you see this same trade-off. If you go with a lower dose, then you have about a 31% increase in excess in stroke or systemic embolism with the lower dose compared to the standard approved dose. Major bleeding, of course, you use a lower dose, is reduced by more than a third. And net outcomes are pretty similar between the two. So that while the 30 milligram dose reduced to 15 is not approved for use, there's some rationale in patients at high risk of bleeding in whom one may consider using this off-label. So there are data, but the default ought to be the approved dosing regimen, which is 60 milligrams, dose reduced to 30 in those patients who meet dose reduction criteria. You see in the far left, I've listed the dose reduction criteria. You reduce the dose of Edoxaban by 50%, from 60 to 30. If a patient has a creatinine clearance of 50 or less, or weighs 60 kilograms or less, or is on a strong PGP medication, and you only need one of those. If you have at least one of those, then the approved dose is 30 milligrams. And of course, that's going to vary around the world. In the US, that might apply to 15 or 20% of patients. In Asia, it's about half the patients who meet one of those dose reduction criteria. There's, of course, additional experience with Edoxaban at 15 milligrams in elderly Japanese patients who were not candidates for standard dose oral anticoagulants. This was studied 15 milligrams versus placebo in the Elder Care AF trial, and you see there was a large reduction of 2/3 in stroke or systemic embolism. So even a very low dose, Edoxaban 15, is biologically active and reduces stroke to an amount that about was seen with warfarin in the old warfarin placebo trials. There is a tendency for more bleeding, even with 15 milligrams. You see a near doubling of major bleeding, although it did not meet statistical significance. So very low dose of Edoxaban, 15 milligrams, very effective to reduce stroke or systemic embolism. I would use this option only in patients who have tried and failed standard doses of oral anticoagulants and nothing else is available. So it's the last option. Now, the bottom line here from Elder Care is in this group of very elderly Japanese patients with AF who are not considered candidates for standard dose oral anticoagulants, Edoxaban 15 milligrams is superior to placebo to prevent stroke or systemic embolism, reducing it by 2/3. Did not significantly increase major bleeding, but you can see the trend in the right-hand panel. So let's go and now talk about each of these 6 groups just briefly. Patients with prior stroke, the DOACs are effective and about equally so, a 14% reduction in future recurrent stroke or systemic embolism, not major differences between the different therapies. There was an 11% reduction in major bleeding amongst patients with TIA or ischemic stroke prior to the studies. But notice that the reduction in bleeding is really seen only with Edoxaban and Edoxaban in the Aristotle and Engage trials. Really no difference between DOAC and warfarin with rivaroxaban or dabigatran in these patients with prior TIA or ischemic stroke. What about chronic kidney disease? Well, this slide's a little complicated, but I'm going to have you focus just on the bottom 2 rows. In patients with moderate CKD, creatinine clearances of 30 to 50, and you see each of the 4 drugs here, all of them tend to reduce recurrent stroke. The effect may be strongest for dabigatran there. But as far as the bleeding risk goes, you see it breaks out again in these same 2 groups where Edoxaban and Edoxaban significantly reduced major bleeding in patients with moderate CKD, and there was really no difference between the DOAC and warfarin with rivaroxaban or dabigatran in the ROCKET trial or in RELY. So in patients with moderate CKD, if you're concerned about bleeding, I think Edoxaban or Edoxaban are a better choice. If the bleeding risk is modest, dabigatran is the one drug that reduced stroke. What about patients with prior coronary disease and undergoing cardiac procedures? So I'm going to share with you a trial-level meta-analysis in patients with a history of CAD. Here is the endpoint of stroke or systemic embolism. You see overall reduced by 24% with some variability across the different agents. With Edoxaban, there was a 35% significant reduction in future stroke or systemic embolism, the only trial that had a significant finding there. For major bleeding, again, rivaroxaban tended to increase major bleeding. Dabigatran was neutral. Edoxaban had a 19% reduction in major bleeding. Again, all these patients had a history of coronary artery disease. And with myocardial infarction, Edoxaban was the only drug that reduced the risk of future MI among patients with a history of CAD. You see a 31% reduction in future MI with Edoxaban compared to warfarin, and there was no effect with Edoxaban or rivaroxaban compared to warfarin, and dabigatran, if anything, tended to increase the risk of future MI. I'm often asked about what about concomitant antiplatelet use, and as many of you know, that in patients who are more than a year out from MI or stenting, we are now advising to stop antiplatelet use and continue with the anticoagulant alone. These data are from the combined AF individual patient level meta-analysis, and basically what you see is patients who receive an antiplatelet therapy did not experience any greater reduction in the risk of stroke, ischemic events, or all-cause mortality. But when you add antiplatelet therapy, then you see an augmentation in the bleeding rates, and that was true of both the warfarin arm and the DOAC arm. So not much to be gained by adding antiplatelet therapy in stable patients, and most of this is aspirin, but you do increase the risk of bleeding. Now, of course, in patients who are undergoing PCI, it's a different story because antiplatelet therapy is very important to prevent this early stent thrombosis. And I'm just going to summarize this meta-analysis, the 4 DOAC AF PCI trials. Major bleeding is increased when you add 2 antiplatelets to warfarin as compared to a DOAC with 1 antiplatelet. And this is not surprising, right? DOACs tend to have less bleeding than warfarin, particularly Edoxaban and Edoxaban. And then 2 antiplatelets is going to cause more bleeding than 1 antiplatelet. So the field has moved away from so-called triple therapy with an anticoagulant and 2 antiplatelets, or to keep it very short, maybe somewhere between 1 day and 1 month. And that's because of the reduction in major bleeding when you use a DOAC and 1 antiplatelet. Now, the price one may pay is this trend of an increased risk of MI and stent thrombosis, particularly early, if you drop the antiplatelet therapies quickly. And so that's why there still may be a role in high-risk patients for a short course of triple therapy, say up to 1 month, in patients that have had complex PCI or PCI of the left main or bifurcation lesion. So still a small role for dual antiplatelets. Probably limit that to your highest risk patients, keep it short, and the majority of patients can go home on a DOAC plus a single antiplatelet. And I just say, looking across the various trials, the results are all consistent. I don't think there's a major difference in the DOACs. It's more about the antiplatelet use. And these findings really help drive the EHRA practical guide, which says for elective PCI, triple therapy maybe till discharge, and then dual therapy for 6 months, followed by the DOAC alone. For patients who are at higher risk with ACS or complex PCI, can consider triple therapy up to 1 month, then slowly ramp down to dual therapy with a DOAC with clopidogrel, continue with that out to 1 year. And by 1 year, the majority of our patients should be on monotherapy with a DOAC. There are different factors that might cause you to want to shorten the duration of combination therapy, or to lower the intensity of the combination therapy, like patients at high risk of bleeding or those who are at low thrombotic risk. And then there are factors that may want to drive in the other direction, lengthen, say, triple therapy or intensify the antiplatelet agents. And that would be patients with high atherothrombotic risk, or particularly if they're at low risk of bleeding. And remember, in all patients, to try to reduce the risk of ischemic events, use the more modern drug-eluting stents to reduce bleeding. We recommend PPI on triple therapy or even dual therapy. Do what you can to minimize the bleeding risks and risk factors, and use a radial arterial approach when possible, and follow them closely. Now, turning our attention to diabetics, some interesting findings here. The DOACs are effective to reduce stroke or systemic embolism in diabetes. I'll point out that only dabigatran, 150 milligrams, significantly reduced stroke or systemic embolism in diabetics, and it was about a 40% reduction with dabigatran. Overall, when you combine the data, about a 20% reduction. On the major bleeding side, however, it was more neutral. There's a non-significant 6% reduction in major bleeding when you combine all the data. But notice in the ENGAGE-AF TIMI-48 trial, Edoxaban significantly reduced major bleeding in diabetics. And I think this is one of the unique advantages of Edoxaban, reducing major bleeding by 21% compared to warfarin in diabetics. And we have speculated why this might be, and then I ran across this paper in JAMA Ophthalmology, and I'll admit I don't read the ophthalmology journals, but someone had shared with me this finding in intraocular bleeding, where overall the trials are pretty neutral for intraocular bleeding compared to vitamin K antagonists. It is a known risk. But notice that in the ENGAGE-AF TIMI-48 trial, there was actually a 38% and a significant reduction in intraocular bleeding in patients with diabetes. So this is another potential advantage of Edoxaban, lower rates of intraocular bleeding, certainly compared to warfarin, through indirect comparisons, looks perhaps more favorable than the other agents. What about the cancer patients? These are very difficult, challenging patients who are often quite ill, can have bleeding related to the cancer. They're on multiple therapies that can interfere with the drugs. We have limited data, but the best available data come from this analysis by a former fellow of ours, Christina Fanola, in patients with active malignancy. And these were in the ENGAGE-AF TIMI-48 trial. So not a history of cancer, but these patients actually had active cancer during the trial. There were over 1,100 patients, And to the left is the efficacy. The red diamonds are patients with cancer. The blue diamonds are those without cancer. To the left of the vertical line indicates that Edoxaban is better. And you can see in patients with cancer, the outcomes of stroke, ischemic stroke, MACE, MI, cardiovascular death, and all-cause mortality, well, not all-cause mortality, but the others, tended to favor Edoxaban over warfarin. All-cause death was neutral. If anything, the point estimate was slightly less favorable in patients with cancer. To the right are the bleeding data, and here you see that in patients with active cancer, Edoxaban and warfarin had similar risk of various bleeding endpoints. So this is the challenge with any DOAC, I believe, in patients with active malignancy. You have more drug-drug interactions. You have the potential for bleeding, particularly it's GI bleeding that one is concerned about with the DOACs. No significant interactions, but the bleeding advantage of Edoxaban seen in the main trial is present in those without active cancer. Once a patient has active cancer, now the bleeding risk is similar to warfarin. And in some of these patients, you want to avoid a DOAC. How about patients with liver disease? Very little data available here. They were generally excluded from the trials. This is a busy algorithm that appears in the 2021 EHRA guide, practical guide. I'll have you focus in on the red box item here, where the recommendations are if the patients have Child's A, liver disease, so mild hepatic dysfunction, you can use any DOAC at a normal dose. At the other extreme, it's not recommended for patients with a severe advanced hepatic dysfunction, Child's class C. None of the DOACs really have been studied, and we don't know what dose and how safe it may be. Now remember that the clearance through the liver and the GI tract is going to be highly variable between these agents. In class B, the guidance is you may use dabigatran, apixaban, and edoxaban, but one needs to be cautious. One should not use rivaroxaban in patients with moderate or Child's class B hepatic disease. So I want to go back to this initial diagram and point out how age is front and center, but what other factors can influence efficacy and safety, and particularly apply to patients of older age, and that is older age patients tend to take a lot of medications. And sometimes when I'm reviewing the medications with my patient, I just feel like they're on so many, and how can we keep track, and what do we know about drug-drug interactions between these medications? So it's important to go back to this figure that I showed you earlier and focus in on the drug-drug interactions. So two important points. One, rivaroxaban and apixaban are the only two DOACs that have significant metabolism through the cytochrome P450 system. So be cautious in patients on concomitant strong CYP inhibitors with these two agents, but better off with edoxaban or dabigatran. And then also remember that all these DOACs are transported through the PGP transport system. And so whether it's a PGP inhibitor, in which case the DOAC levels are higher, or a PGP inducer, in which case the DOAC levels are lower, one needs to be cautious. And remember, as we discussed, that edoxaban was studied at a reduced dose in patients with strong PGP inhibitors. There's a lot of guidance that's available through the 2021 ERJ practical guide. There's too much to go through, but I just want to show you my simple summary. They use this kind of color-based system to indicate when to be concerned. White is no drug interaction, yellow, orange, there may need to reduce the dose, and red, don't use a DOAC with these agents. I went through the 19 drugs that were listed in the 2021 EHRA practical guide as being a potential concern. And so here's what I learned. Well, first of all, remember these two lessons. All DOACs are affected by the PGP transport system, and only edoxaban was studied in patients on a strong PGP inhibitor, and you should reduce the dose by 50%. And remember about the cytochrome P450 interaction with rivaroxaban and apixaban. They had 19 drugs in this EHRA practical guide, and I just broke it down into, was it okay to use the agents? I thought if it was in the green or the yellow category, you may use the DOACs. If it's in the red, the instruction is to avoid the use or no data. I thought maybe don't use that particular DOAC, and I just tallied them up. So if you look at, when it's reasonable to use a particular DOAC, you see differences across the board. Edoxaban had the most confidence in 14 of the 19 therapies compared to 9 to 11 with the other agents, and whereas one should not use apixaban, dabigatran, and rivaroxaban in 8 to 10 of the patients. Now, why am I making such a big deal about drug-drug interactions? Well, our elderly patients are often on multiple medications, and if their interactions particularly resulting in slowed clearance or higher drug levels, patients may bleed. And indeed, I pulled together 3 papers on polypharmacy and looked at the outcome of major bleeding. So there's one with rivaroxaban, one with apixaban, one with Edoxaban, all published. You see the citations in the lower right. And I broke them down into kind of low number, moderate, and high number of co-medications. The methods they use are slightly different, but this does roughly break up the population into similar 3 groups. And you see, as the number of co-medications increase, there is a relatively higher risk of bleeding as the number of co-medications increase, such that the statistical interaction test is significant. With rivaroxaban, actually, once you get to 5 or more co-medications, there's a tendency for more bleeding with rivaroxaban than with warfarin. With apixaban, if you're on 5 or fewer co-medications, you have a nice reduction in major bleeding compared to warfarin, but that benefit erodes as the number of co-medications increase. With Edoxaban, there's no effect on the number of co-medications. It was a consistent, roughly 15 to 23% reduction in major bleeding, whether a patient was on a number of co-medication, and here we did it by the number of classes of medications. So one could be on multiple drugs within a class. So the counting's a little differently. And you might say, well, why did Edoxaban not show a signal towards more bleeding with polypharmacy? And I have 3 potential explanations. First, remember, unlike rivaroxaban and apixaban, Edoxaban has very little cytochrome P450 metabolism. And if your patient's taking a handful of pills, chances are that one of them may be a CYP inhibitor. Secondly, remember, Edoxaban was the only drug that was dose reduced for patients on strong PGP inhibitors. And lastly, and this applies in comparison to rivaroxaban, the reduction of dose of Edoxaban is 50%. With apixaban, it's also 50%, but few patients were dose reduced. With rivaroxaban, it's a more gentler 25% reduction from 20 to 15 milligrams. So for polypharmacy, we see this preservation and a reduction in major bleeding with Edoxaban that's not seen with the other 2 10A inhibitors. So I hope at this point now you're starting to begin to see how we might choose between the DOACs. Hopefully a light bulb has now gone off in your head, and you realize that there are important differences here, and there's room for a 4th DOAC, Edoxaban, with certain areas where it may be the preferred anticoagulant. So I have this slide. It's kind of busy. It's probably best taking 10 or 15 minutes to go through, and I don't have that, but you can see that there's room for all the DOACs. And at a high level, I'm going to pick out a few examples of patients, high bleeding risk, or they're very elderly, then pick the drugs that have the lowest incidence of bleeding, and that's apixaban or Edoxaban. In patients on strong concomitant cytochrome P450 inhibitors, remember that dabigatran and Edoxaban are the 2 that have little or no cytochrome P450 inhibitors. In mild to moderate liver disease, here we have data with Edoxaban where patients did well, although the bulk of them had mild liver disease. Dabigatran has the least hepatic clearance because it has the most renal clearance. So maybe you choose Edoxaban or dabigatran. We went through data with prevention of ischemic stroke, particularly ischemic stroke in diabetics, And there, the agent that had the best reduction in ischemic stroke was dabigatran at 150 milligrams. And then at the bottom there, I have patient preference. Consider once daily formulation that's available with Edoxaban or Edoxaban. So you see, there's room for each of these agents depending on the patient profile. And so I hope that by now hearing this talk, you feel a little more comfortable about where Edoxaban fits in comparison to the others. There are, of course, different ways to look at this. Here's another color-based scheme that I've set up. Green means that it's good or best amongst the four agents. Orange is neutral, red is unfavorable. For efficacy, dabigatran has quite a lot of green. For safety, Edoxaban and Edoxaban have a lot of green, and Edoxaban, frankly, has quite a lot of green categories as well for efficacy. The low dose data really only exists in any great numbers with Edoxaban, and there's a whole low dose regimen that was studied in over 7,000 patients, and we talked about drug-drug interactions, which are less common with dabigatran and Edoxaban. And remember the dosing, and remember for once daily dosing of rivaroxaban must be with food. So these are kind of my personal opinions, and happy to discuss them further. I also had developed a simple approach to treating our frail elderly patients or patients with multiple comorbidities. It starts at when you identify that elderly frail individual, can they take any anticoagulation? If not, then maybe they need a procedure, a left atrial appendage occlusion device, or maybe the 15 milligrams of Edoxaban. If patients have no absolute contraindications to DOACs, then give them a DOAC. Otherwise, warfarin is a potential, although risk of bleeding is high in these frail patients. And then just remember, when you're choosing a DOAC in an elderly frail patient, get the dosage right, preferably of Edoxaban or Edoxaban. If they meet dose reduction criteria, then do lower that dose by 50%. So with that, I think I'll bring my prepared comments to a close. DOACs are favored in most patients. The four DOACs are not the same. There's many differences in PK/PD and how they were studied in the trial. Remember that in our elderly frail patients, the bleeding profile is better with Edoxaban or Edoxaban, and in general, one should stick to on-label dosing, especially in Asian patients. And if we have time, I can show you data specifically in patients from Asia. So with that, I think I'll bring the talk to a close and look forward to a discussion and questions.
Dr. Diwan, I think you're on mute, sir.
Can you hear me?
Yes.
Right.
Yes, we can hear you now.
Okay, Dr. Giugliano, thank you very much for your presentation. And today, with this fascinating exploration of Edoxaban, we really learned a lot of new things. And I'm sure our viewers from various cities in India, they'll be able to decide how and where to use which type of DOAC and get more usage of Edoxaban, right? And with this, we open our forum for the questions. But before we go over there, there was a query from Dr. S.K. Panda saying, what about the patients with hepatic failure? I think you have already covered that quite well in a couple of slides. So the answer is obvious, unless or until you want to make a comment or so on that.
Yeah, we did study about 1,100 patients with liver disease and Edoxaban. The thing is, it was mostly mild, very few class B. The patients did equally as well. The pharmacokinetic, pharmacodynamic properties, results were not dramatically changed. It's a challenge what to do. I mean, even warfarin is difficult in patients with severe advanced liver disease. I'd probably use a VKA because you can monitor anticoagulants, although even monitoring the INR is tricky, right? Because they can have abnormal INR. Sure. So it's, we don't have a good answer there.
All right. Okay. Now we invite the speakers, the queries from various locations in India. So first we begin with location Tajlands in Mumbai.
from the audience?
Yeah, now we can hear you, Aditya. Please go on.
Yeah, any questions from here? Okay.
All right.
One question is there.
Sir, from Calcutta. Okay, we have here some questionnaires.
No,
So,
we'll come to Calcutta. See,
Acha.
please, we are coming one by one to all these locations. So we are coming to Calcutta after this. Okay.
Okay. Anyone from Mumbai? Yes. So please come here. Come here, sir.
Yeah, good evening, gentlemen. My question is, if somebody has a cerebral venous thrombosis, so what will be the treatment protocol with an oral anticoagulants?
Yeah. Yes, thank you for the questions regarding cerebral thrombosis. Yeah, I don't think any of these drugs have been very well studied there. And I must say that I would treat these patients in consultation with a neurologist. I don't have an answer for you. I mean, in theory, they ought to be effective, but you know, these weren't widely studied.
Thank you.
Any more questions? Please come, sir. Please come. One more query is there. Please, sir.
So, Aditya, please let the doctor say his name.
Yeah, good afternoon. I'm Dr. Mayur Mewada from Mumbai. I would like to ask, sir, is there any oral anticoagulant we can give in pregnancy as of now, or anyone is under trial or something? Even under trial.
Yeah, no, good question. No, the oral, the DOACs haven't been well studied in pregnancy, and so they should be avoided. I think the answers are still low molecular weight heparin and warfarin may be used, you know, in the middle stage vitamin K antagonists, but no, not well studied.
Yeah, thank you.
Any more questions?
All right, with this, Aditya, now we'll Aditya.
Sir, the last question here. Last question here, sir. Sorry.
Okay, so last question from Patil and then Mumbai.
Yes.
Okay.
Please.
Dr. Robert, my question is, given a comparison between Edoxaban and Edoxaban in patients with atrial fibrillation or coronary artery disease, which one you will prefer?
Yeah, I think in patients with coronary artery disease and atrial fibrillation, one could choose either Edoxaban or Edoxaban. I think I prefer one of those because the risk of bleeding is often higher in these patients, and those are the two that are better profile. I would look a little more and ask some things like, is the patient diabetic, where Edoxaban had some advantages? Is the patient on polypharmacy or drugs that interfere with Edoxaban's metabolism? Then I'd favor Edoxaban. Does the patient have a strong preference between once daily or twice daily medicines? You know, but I think they're both good choices, and then you could dig a little deeper to get the best.
I think you already said once a day would be compliance would be better than taking twice a day.
Definitely so. Yeah.
Thank you very much. So,
thank you, Aditya. Thank you very much for your presence over here, Aditya. Now we just shift from London IBIS.
Mumbai, yeah, IBIS, yeah.
To IBIS, yeah. So, yeah, please go ahead with the questions.
Hi, sir. This is Dr. Ankit Biani. A quick question is there a reversal agent for the drug apart from PCCs that we usually use?
Yeah, there is a reversal agent at Nexanet Alpha. It's quite expensive. It's not universally available. The PCCs would be recommended for your use. Other agents used to warfarin are ineffective, vitamin K and FFP. So you would use the 4-factor PCCs to reverse a DOAC, any of the DOACs. There is a specific reversal agent for dabigatran, the diracizumab, a monoclonal antibody. But honestly, and people sometimes, I think, have been a little bit misled. With warfarin, if you have a life-threatening bleed, the answer is not vitamin K, it's not FFP, The answer is a 4-factor PCC for life-threatening bleeding with warfarin. So essentially, it's the same option with the DOACs and the same with Edoxaban.
Thank you.
All right. Okay. Any other queries from IBIS Mumbai?
Yes, sir. Yes, sir. We have a question. Yeah.
Speak directly.
Yeah.
Yeah, my name is Dr. Satish Vaidya from Thane.
Hello, sir.
I want to ask you, is there any data on use of Edoxaban in chronic coronary syndrome and prevention of pulmonary embolism and deep vein thrombosis?
Yes, there are data in chronic coronary syndrome. It is effective. You know, I think the bleeding risk, one needs to consider if they have an indication for an oral anticoagulant, then you would do that alone. If they have also an indication for antiplatelet use, you would need to combine it with an anticoagulant. But after a year post-coronary syndrome, ACS, you should just go with the anticoagulant alone, and there are data and trials. There's quite a bit of data with DVT and PE. They're the largest of the trials done with a DOAC in DVT and PE. It was the Hokusai VTE trial. We would just need another complete session to cover the data in VTE, because, you know, there's VTE prevention, there's initial treatment and management of acute VTE, and then there's long-term secondary prevention. So I was not able to carry that. But the key study with Edoxaban is called Hokusai VTE.
Yeah.
And what dosage?
It's the same, 60 milligrams, dose reduced to 30. Yeah.
Thank you.
Can we ask? So we have a question from Chennai, Dr. Diwan.
See, I am coming to one by one, but of course, the next turn is Chennai hub only. So I wanted to know, first of all, from IBIS, is there anything, is there any other questions? All right. Okay. Thank you so much. Kuldeep, we sign out from here, and now we move to our Chennai hub. Yes, please. The questions from Chennai.
I'm Dr. Rakesh Gopal.
Hi.
I have to make 2 points. One is, see, there is 17% reduction in the cardiovascular outcome in patients who are on Edoxaban compared to Apixaban. So do you think, but there were more bleeding, right? So if the drug was used as a twice daily dose, do you think it would make a difference?
Yes, you'd have even more bleeding with twice daily dosing. And I will show you this quickly. So slide 11. Let me see here if I can show this. But this was studied in phase 2, and there was even more bleeding with twice daily dosing. Let me show you the key slide here.
While you're looking for the slide, I can ask you to add this. In Edoxaban, which was once daily, was changed later on to twice daily. In the chronic disease. Please go ahead.
Yeah, I know for atrial fibrillation, rivaroxaban is once daily. So here's a phase 2 data with Edoxaban compared to warfarin and atrial fibrillation. And you see that the lowest bleeding risk was with 30 once daily. Then there were 2 ways to get 60 milligrams studied, 60 milligrams once daily and 30 milligrams twice daily. And there's more bleeding with BID dosing. And then there was the highest rate with 60 milligrams twice daily. Well, that's a total of 120. And the explanation is that it's the trough levels that best predict bleeding, not the peak levels. So the observed incidents are the black triangles, and you see the black triangles and the observed are very tightly correlated with the trough levels. So it's not peak that predicts bleeding. Here's another way to look at the trough levels predict bleeding as you go across these doses, not the peak. So it's properly given a once daily. I wouldn't give it twice daily.
One more thing is like, what is the in cancer patients how do you compare Edoxaban with a Caravaggio trial where the apixaban was tried?
Yeah, that's different, right? So that's DVT and cancer patients, and we need a whole nother session for that. I don't think there are really major differences on the DVT side in efficacy. In bleeding, there may be some differences, particularly with dabigatran and rivaroxaban having higher risk for bleeding. But I think we have to do another session to go into that in detail.
Yeah, but Caravaggio is currently the only data on cancer patients, which is quite a good number of patients who are enrolled.
No, that's not true. There's a number of studies in cancer patients with Edoxaban as well.
Number of patients, I said. I said number of patients in Caravaggio.
Yeah.
Much more than any other molecule. But yeah, so that
there's good data with all of them. There's good data with all of them. I could send you half a dozen papers in cancer in randomized.
I know. Yeah, I agree with you.
Yeah.
All right. Thank you, sir. Thank you very much.
Thank you.
Now we move to a query which is coming, like, Dr. Robert, like, what happens if the patient is having creatinine clearance more than 95?
Yeah, that's a good question. Well, I don't think any of the DOACs fare all that well in patients with creatinine clearances that are high. Let me get to that slide in just a second, and I'll share with you a couple data, some data we have. So this is one that has been well studied. And again, the field lacks the head-to-head comparison, so that's what we would really like to see. But let me show you these few slides. So here are the data that were presented by the US FDA at the time that they were looking at approval of Edoxaban. And so the way the FDA presented the data is two groups, those with creatinine clearance 50 to 80 and those with creatinine clearance above 80. And this is talking about stroke or systemic embolism. So with dabigatran, still favorable to dabigatran. This is the hazard ratio, but less favorable in those with higher renal clearance, higher creatinine clearance. With rivaroxaban, now the point estimate favors warfarin. With apixaban and edoxaban, there were large directional changes here, hazard ratios of 1.4 and 1.6 in patients with creatinine clearances 80 or above. And this is really hard to explain because of all these agents, dabigatran is the most renally cleared. So if it just had to do with drug levels, then the drug levels should have been even lower here. And apixaban is the least renally cleared. So why does it have a 35% excess of stroke or systemic embolism in patients with creatinine clearance above 80? And edoxaban was even higher at 1.6. Now, it's complicated, right? Because the risk profile of these patients is different. The risk profile of the patients was lowest in Aristotle, so they're lower risk for stroke. The time in therapeutic range was very high with edoxaban. So some of this hazard ratio is because look what happens to the event rates with warfarin. In the stroke or systemic embolism in the warfarin arm, if your creatinine clearance was below 80, it was 1.23% per year. It was reduced by more than half in those with creatinine clearance above 80, and in part was because they were very well managed at TTR of 68. That's much higher than the TTR in Rocket. So, some of this has to do with the drug, some the renal function, some the risk of the patient, and some the time in therapeutic range.
Lovely. That's a very explanatory answer.
Yeah.
Okay.
I would just, if you can indulge me for just a second, here's what happens when we did the meta-analysis, individual patient level data, and these are creatinine clearance on the x-axis, so poor renal function to supranormal renal function. And notice for stroke or systemic embolism, the point estimate crosses the line of unity and starts to favor warfarin at around 110.
Right, absolutely right. Okay, so from here we now move to a couple of cities left. That is, first we go to Delhi. So, yeah, from Delhi, any queries are there?
Yes, sir. Yeah.
Yes, please.
Hello. Yeah. Presentation. I would like to be congratulating you. And I was interviewing. You are Italian origin. That's why you're Giugliano, Robert.
Giugliano, yes, you're right.
Giugliano.
Okay, I'm Dr. Vivek Gupta. I'm cardiologist in Delhi Apollo, and of course, I joined a little late. But there are two interviewing questions, which are very simple questions. You had an engaged AF trial, which was in 2013, randomized trial published. After that, there have been so many American president change, but there have been no randomized trial for rheumatic mitral stenosis. I was reading your article in Lancet where you Jack in 2019, where you said that off-label use can be done, can still be used in rheumatic mitral stenosis, atrial fibrillation. So what is your on take? Because we have a lot of such patients here, and we are still depending upon warfarin with monthly or twice a month prothrombin time and INR. So why it is not coming despite having the efficacy in non-rheumatic atrial fibrillation? And most of the randomized trials have actually excluded mitral stenosis related fibrillation.
Right. No, it's a good question, and obviously very important in the subcontinent. I understand, and in other parts of the world, Southeast Asia as well as Latin America, where rheumatic disease still has a high prevalence. There was one randomized trial performed, and the results looked surprisingly good for warfarin. In part, with warfarin, you have that follow-up in contact and adjusting the dose and so forth. And rivaroxaban didn't fare as might have been expected. I think in part it will depend on if you can control the INR well. Maybe warfarin's not a bad choice, but if the INR is going to be very poor and low, then you're not really protecting the patient. And I think a DOAC is a reasonable option there. The short answer is we just need another larger and better conducted study to answer the question. But these patients are extremely high risk. They obviously need anticoagulation with moderate to severe rheumatic mitral stenosis. And I don't think we have the final data. We just have one trial.
So we cannot use it off-label. Should we or should we not?
I would try a VKA first. If the time and therapeutic range is poor, I think as physicians we often go off-label. It's off-label, but it's on data, because there are data.
Thank you. Thank you very much.
Thank you very much. And finally, we move to Kolkata hub now.
So two questions more from Delhi, please.
Deepak, we are running short of time, but okay, very quickly, yeah?
Yeah, I have two questions. One is, if a patient has LV clot, can we give NOVAC to that patient? I personally feel that we can give, but what's your opinion? Should we use NOVAC?
What does the patient have?
LV thrombus.
LV thrombus. Oh, yes.
Yeah.
Right. So the emerging data look favorable for use of DOACs, but we really lack a large trial to prove it. But I will say in practice, we are using it. I do tend to follow them up with an echo at, say, 1 and 3 months. But I think you can use it. But if you ask me, it's not class 1 level A evidence yet.
Yeah, and the second, this thing is like a patient of CAD with AF, post PCI. You mentioned after 1 year. In many patients, you can just put the patient on NOVAC. So there you think 30 milligram is as good as 60 milligram?
Well, yeah, good question. I would only use 30 milligrams of Edoxaban in that patient if they met dose reduction criteria, which I think in India would be roughly half your patients. That's what we found in the trial.
Thank you.
Okay, thank you very much. Deepak, can we move now?
I think so, sir. Any more question? One.
All right. Thank you, Deepak. Thank you very much.
So only two questions. Dr. Makkar, please.
So quickly, I'm Dr. Makkar. What's your strategy, Dr. Robert, in choosing a DOAC in a patient of SLE who has lupus nephritis and is progressing?
Yeah, that's an easy one. I use warfarin. I don't think we should use the DOACs in patients with antiphospholipid syndrome. The data suggests they're inferior.
Okay, and what's the risk of not using, DOACs?
Well, I mean, first of all, this patient warrants anticoagulation, but if they've had thrombosis and APLS, with warfarin, you have the well-known risks of, drug-drug interactions, bleeding, intracranial bleeding, etc. But I think for efficacy, the 5-MK antagonists are absolutely indicated here. The guidelines are quite clear.
Okay, thank you.
Mm-hmm.
Thank you very much.
Thank you, sir. Thank you very much.
With this, we now shift to Kolkata hub, and that's the final hub we have.
Sir.
Yes, please.
Robert, it was a fascinating lecture. It was, in fact, a fantastic voyage. Good afternoon to you and good evening from here. Now, in the backdrop of the Richard's data that were published in last year, 24 stroke, do you think we should use Epixa in patients above 80 years, those who are very old?
Yes, I think that there's good data for using Edoxaban or Edoxaban in patients over 80, and in Edoxaban we even published in patients over 85. And then if you look at the elder care trial, they had patients over 90 with Edoxaban. So I think, warfarin gets worse and worse the older the patient is. So I think the argument becomes even stronger with better data the older patient is, that one should use a DOAC. And here clearly the preference is for Edoxaban or Apixaban. There's good data with both of them.
Thanks. And again, in the backdrop of the EPIC-CAD that was discussed in last year ESC also, in Korean data, I think if we are treating chronic stable angina with AF, only Edoxa is okay?
No, I think chronic stable angina, once you get to 1 year after ACS, 1 year after PCI, one could use just the DOAC. There are good data with rivaroxaban, Apixaban, and Edoxaban. There's not been much comparative data there. But I think that the most important thing is to stop the antiplatelet unless there's a clear indication after a year. And I think you could use any of them and then look at other things like the age of the patient. If they're very elderly, I'd favor Apixaban or Edoxaban. Look at their other concomitant medicines. Do they have diabetes, renal insufficiency, etc.?
And regarding EGFR above 95, you have given already certain data. Is the black box warning deleted or still exists?
Yeah, it still exists. It's amazing. I have to tell you, I've never seen anything like this in my life. I'm at the podium at the FDA presenting the data. The FDA reviewer puts up the slide showing the same problem with the other DOAC, specifically Apixaban, and somebody says, well, why didn't you bring this up, 3 years ago when Apixaban was being reviewed? And the FDA had no answer. So I think, it's just unfortunate the way it came about. I would say, and the data are clear, and we looked at patients with high BMI or high creatinine clearance, warfarin does well in those patients whose BMI is above 40 or creatinine clearance above 100. So part of it is the DOACs may not be as effective, but part of it is that warfarin does well. And those tend to go together, right? It's a young person, high BMI, high creatinine clearance.
Thank you so much.
You're welcome.
Thank you, sir. Thank you very much. Okay, there is
last question.
Please
Can
go
I
ahead. Yes, please.
Yeah.
No, I'll just have.
This is the best part.
You honestly have described the uniqueness of this molecule. About one thing about the drug interaction.
Yeah.
We get patients where predictable drug interaction is less. We don't use dronedarone. our uses of amiodarone in the practice has calmed down. We know that rate control is better. The only thing is, if somebody is ill and getting fluoroquinolones or other antibiotics, those are issues which can come up. So, what will be your practical tips for this patient? Suppose somebody is on NOAC, not Edoxaban, but other NOAC. Mostly we are using Edoxaban or Rivaroxaban. In that case, if this patient gets acutely ill and needing hospitalization, getting some antibiotic where we may not be aware of this PIP or CIP interaction, what will be your practical tips? This is not read in randomized trial. Thank you.
No, good question. My practice would be to use a parenteral heparin, low molecular weight heparin or intravenous heparin, depending if the patient's in the ICU or out of the ICU setting. Enoxaparin would be a good choice to prevent atrial fibrillation, risk of thrombosis and stroke.
Thank you.
Sure.
Thank you very much. And with this, I think that this time is already over, but we are extending it. So another couple of minutes, and the query which are coming from the online attendees, like other than these cities, there are several online attendees. One query is that of the DOAs, Edoxaban has the advantage of lowest bleeding complications. And can it be given once daily, unlike Edoxaban, which has also a low bleeding risk?
Yeah, Edoxaban should only be given once daily. Yes.
So that's the best advantage of Edoxaban, of course.
I think that's one advantage. Yes.
Yes. Yeah. All right. So with this, I would like to invite Mr. Allat Mahajani to say a few words. Mr. Allat. And then Aditya can give the vote of thanks.
So, Dr. Robert, we are sincerely thankful to you for the quality time and the quality presentation. It was a great learning experience, I suppose, for each one of us. I must also like to thank all the attendees, and I'm sure that it has been a good session and an academic feast. And I would like to also thank Dr. Diwan for fantastic moderation. And I would request Aditya and the entire team to say thank you on behalf of Juventus. Yeah.
Thank you, Dr. Giugliano. It was a very great experience, and thank you to Diwan sir. Thanks all the 5 hubs coordinator, Delhi, Kolkata, Chennai, and Mumbai IBs, along with rest all our coordinators. And we hope to see you again, Dr. Robert Giugliano.
Thank you. Thank you very much.
Thank you, sir. Thank you.
Pleasure meeting you. Pleasure.
Bye-bye now.
Thank you.
Bye.
Bye.
Bye.